All right, perfect. So today's webinar is meant to discuss the different birth outcomes that we're able to measure and the programmatic and policy directions that we can take to improve them. Our presenters today are going to be our own data divas, Carol Gilbert and Lynne. If you have any questions again during the webinar, send them to the chat box or press *7 to unmute yourself. So what I'm going to do now, I'm going to mute the line.
The conference has been muted.
And I'm going to ask Carol and Lynne to please press *7 to unmute yourselves. Can you guys talk to see if it worked?
Here I am.
Okay,
Carol.
I hear Carol. Perfect.
Can you hear me?
I can hear Lynne too. All right, magnificent. So with that, why don't we go ahead and get started?
Hi. So Carol, Lynne and I are both going to be presenting, but I'm going to start. This is Carol Gilbert. I'm the Senior Health Data Analyst. So I've done this before for the Equity Institute several times, something similar, but we've added a bit this round. So I hope you'll get something out of this. This is an overview of birth outcomes, inequities, evidence, and interventions. So the key points we're going to try to make here are that an overview of birth outcomes, what can we do in the Equity Institute, the general directions we have available for intervention, and the potential roles you can have. So part of what you can do is assess what the problem is, what you want to go for, and also planning and implementing an intervention, and then monitoring change. And these are standard public health practices, but we're going to talk just specifically about how they apply here to the Equity Institute. So we have complex and varied causes for birth outcomes. I mean, there's a lot of evidence that shows that we can't just fix birth outcomes by taking care of the access on the lower left-hand corner. Access to prenatal care, for instance, doesn't do it. Even access to longer-term health care doesn't do it alone because it has to do with maternal health over the life course and intergenerationally, so we can't fix it all at the point when they're trying to be pregnant. And it also depends on social and economic circumstances now and over the life course. So this is a complex issue. So these are some of the outcomes that we could have for the Equity Institute. These are birth outcomes, so problems that the baby can have in addition to dying and being premature. Problems that the mother could have are fair game. And mortality, of course, infant death, fetal death, and that's the same as stillbirth. And then very preterm birth, early preterm birth. I'm putting these in different categories because they're different problems we find out with different solutions. And then breastfeeding is also an outcome that we could do, an unwanted pregnancy. So we've sort of condensed those many, many outcomes into 6 major areas, and that's what we're going to cover today. First, I want to stop and say, what do we mean by disparities in birth outcomes? It's really important to know that a disparity is a difference between groups. We usually define differences in terms of subtraction or division. So it can be a ratio if it's division, like an odds ratio, or it can be subtraction, just a strict mathematical difference. So we don't say one group has a disparity. Well, we just compare groups. So we say one group has poor outcomes compared to another group. So disparity is a difference. The first one we're going to talk about is mortality. So infant mortality rates by race and ethnicity in the United States, we've had a constant disparity. If you measure in terms of difference from that top light green line down to the total or down to the white, it's a big difference, but it's also a big ratio. So if you divide the black by the white, a lot of times we'll see that black has 4 times, or now it's more recently, it's more like 2 times in many places, the white. And this is infant mortality rates by race ethnicity. In 2014, those rates are continuing. Those disparities are continuing. So in the next few slides, we'll talk about how we use local data to figure out where the most excess deaths occur. In our Equity Institute, we talk about excess deaths as preventable, as our proxy for preventable deaths. But that is the measure we use for equity, is when we eliminate excess deaths in one group over the majority or over another group. So we'll try to use local data to figure out where the excess deaths are occurring and choose a topic for intervention. And these are some of the steps we might take. We'd find areas with most theoretical impact that we could have, and that's what we can do with the data. But we also need to assess our local strengths and capacity, look at published program evaluations, what kinds of things can be accomplished about these disparities, and then we have to try to project what impact we could have. So these are causes of death organized. This is the death certificates. Vital records data gives us cause of death, and these are the major areas of cause of death. So prematurity and perinatal conditions, congenital anomalies, SIDS and suffocation, SUID, infections and diseases, accidents and assaults are the major areas that we see for infants. And prematurity does cause about a third of infant deaths, and it causes more than that for excess infant deaths. And prematurity also is linked to SIDS deaths. So prematurity gets a bigger thing, and infections and diseases. So this is how the causes of death look in the USA in 2014. Black non-Hispanic, you can see that big 2.57 stands out. This cause of death rates, cause-specific mortality rates, black versus white non-Hispanic in the U.S. So we can see that perinatal conditions, which are many of them related to prematurity, is a major factor, and congenital anomalies is also big. But what we're going to do the next step is look at how these causes vary across cities. And as you guys know that, I mean, most of you are from urban areas or large counties at any rate, and you can see that these are not the same. Perinatal conditions is a big cause, a bigger cause in Shreveport than it is in Hamilton County, and Ramsey County in Minnesota is somewhere in between. Congenital anomalies is also varies. And accidents and assaults in many places they don't come up at all. They just don't happen very much. They're so rare that they're not measurable. In other places they do come up. So cities are very different. So we need to look at cities and not the USA rates or state rates. So going back to our original rates from 2014 for the U.S., we also want to look at what differences mean. This is the disparity part. The first two columns you've seen already, black and white. Then the third column is difference, and we say excess mortality for the difference, and that is just subtracting the 2.57 minus the 0.73 to get the 1.84. And the farthest right column is the ratio, and when we talk about ratios, we divide, so we say black deaths are 3.52 times the white deaths. White mortality is, so this is what the disparities look like. And when you can see that the disparities are not, when you look at it in terms of disparity, first of all, ratios and differences give you a little bit different picture. Difference shows clearly that perinatal conditions is really a big chunk of the excess. Ratios give you a little bit different picture, but both of the ones that are high are closely related to prematurity in the ratios. So this is the same data just shown in graphical form. For those of you who are visual, you can see that perinatal conditions is a lot of that excess mortality. Black perinatal conditions is a big deal. And then again, this one, newborns affected by maternal complications. So this is sort of you're beginning to get a picture of how the data steers you toward prematurity. Then we also need to talk about a reference group. We can go beyond just saying black versus white and talk about a population that's healthier, that's a real population, and that includes socioeconomic characteristics as well as race. And one of the best ways to use socioeconomic characteristics is with maternal educational attainment. This is a measure of both the mom's education, but it also tends to be a measure of her her upbringing, her parents' education level, and the value her parents place in education, and so her parents' socioeconomic status. And since birth outcomes are intergenerational and education is intergenerational, this can be a good proxy. And so we often define the reference group in terms of white women who are more educated, or also age limits are sometimes used in the reference group. We could use marital status, and you can choose a reference group, at least in our methodology that we use, which is the perinatal periods of risk approach. So this is how the reference group differs from the white group in the U.S. population. You can see one of the big differences is in congenital anomalies. The reference group's a little bit better, and they're similar. Another one is in perinatal conditions, where they have a little bit of a difference. So this maps Black excess mortality by cause of death. And perinatal conditions is a big cause of excess mortality, so it's a big cause of our disparity. But it isn't the only cause. And SIDS and suffocation, which is this 12.8%, is a big chunk. And this varies a lot from place to place. So this is something that you want to look at. And so do infections and accidents. They vary quite a bit from place to place. And the perinatal periods of risk approach, which we're not going to teach in this session, is a sort of an organized way to get at all this excess mortality at the local level. It walks you through what we just did and then goes beyond there to sort of aim more carefully at which risk factors are important. And the public health roles, again, we need to assess whether people who need care are receiving it. That can be one of our ways that we address disparities. We can assess the reasons for the gaps in care, why they aren't receiving it. We can develop policies that address those reasons and assure that people are getting appropriate care and that outcomes are improving. And we also have an education role. We can also intervene when the best care offered isn't the best care received. A lot of times that seems to happen, that we have the greatest hospitals, but the people who need it most are not getting the care from those great hospitals. So we can be the ones who connect with the local community and try to find out why that's happening and how that can be improved. But one important part that we sometimes don't think about when we're designing programs is how are we going to know if we succeed? We can use, this is the second very important way that we use data. We can use program data to see that if we succeed, and that's what we most commonly do. But we need to check as we're making these plans in the Equity Institute, are we going to have access to that program data? And is it high quality, and is it consistent across sites? Will it give us the answers we need? And then the other question is, what proportion of the population do programs reach? So are we going to be able to see this difference at the population level? Another way we monitor success is to monitor policy data. So have there been changes in policies and practices that would impact a lot of people? Are hospitals changing the way they do business? Are there new laws or things that would make a difference to the whole community? But we want to stress that it's usually possible to monitor our success using population data. So our existing sources that include everyone or represent everyone in a sample, like Vital Records and PRAMS and BRFIS and the American Community Survey, those are good sources. We don't want to be in a position of having to try to do a survey. That just doesn't work. Existing data sources that represent an important subset can also be useful, like Medicaid claims data. And in some places they have universal screening tools for all pregnant moms, which may not be exactly universal, but may be pretty close and may be useful for that purpose. So remember, when you're planning your program, how are you going to monitor your success, and what data sources do you have available to do that? And Lynne is going to take over.
Lynne, try going to the next slide. Okay.
Let's see.
And I need you
Sorry,
to,
everybody.
Yeah.
Technical difficulties.
There
Okay.
you go. You're good.
That should be the full page slide. So I'm going to pick up where Carol left off. I'm going to start with SIDS and SUIDs information from the death certificates. So risk factors for SIDS or sleep-related deaths can include prematurity, unsafe sleep, an unsafe sleep environment, and smoking. And these are all modifiable risk factors, and I'll go into a couple of them today. And so we all know that the AAP recently updated their sleep recommendations, and it includes, having the baby sleep on its back, without blankets, without pillows, no stuffed animals or anything like that, and of course no smoking around the baby in the home, ideally. And they've also talked about using a pacifier and the importance of breastfeeding. And if your data shows that safe sleep is an issue in your community, there are some potential directions for addressing safe sleep, which include educating moms in the delivery, or after they've had their baby, not while they're having their baby, but after they're having their baby, and also educating any caregivers, which includes the grandmother or the significant other, the husband, the father of the baby, so that everybody who could be responsible for the baby is aware of safe sleep practices. In addition, birthing hospitals can also practice safe sleep behaviors themselves. Of course, we have public health communication, general education for women who are expecting or who are planning to have a baby. And counseling during prenatal visits and well baby visits are also important, just to keep safe sleep at the forefront of the mother's concern. And also for daycare providers, they need to be looped in on the conversation as well, so that while they put the babies down for a nap, the cribs are safe, it's a good sleeping environment for the babies while they're under the care of the daycare provider. And on this slide, you also see two resources that you could look at for recommendations for reducing SIDS, SUID, and maybe things that could help influence behavior change. So we've alluded to this before, but public health's role in reducing SIDS, SUIDs deaths include monitoring the occurrence of the deaths, even if we monitor through other variables, which I'll get into on the next slide. But of course, managing or changing parent-caregiver behavior, counseling from your OB or from the pediatrician, and of course, hospital policies and practices. So for monitoring SIDS and SUIDs, it can be kind of hard just because the rates are unstable at a local level. So instead of looking at SIDS, SUIDs on the death certificates, we could also look at smoking behaviors, which are recorded on the birth certificate, on prams, and in births. We could ask the parents if they are using safe sleep positions, appropriate cribs and bedding through prams, and we can also see if the infants are exposed to smoke through prams. And then also we can look at daycare policies, practices, and the same for hospitals. And so these are just a few of the resources you can look at if you are examining safe sleep within your community. So I'm going to stop there and see if anybody has questions up until this point, either about safe sleep or about anything that Carol might have covered. Feel free to unmute yourself using *7 or chat into the chat box. Okay, so Carol's telling me that she isn't seeing anything in the chat box, so we'll go ahead and move on. Related to safe sleep is also tobacco. And as we all know, tobacco impacts birth outcomes in a number of ways through prematurity, small for gestational age, stillbirth, congenital anomalies. All of these things are impacted by tobacco use while pregnant. And Also important is secondhand smoke. So after the woman has had her baby, is she smoking around her baby, or is anybody else in the household smoking around the baby? So this is just a map of current cigarette use among adults in 2015 from Burfus, and we can see here that smoking is still pretty prevalent in the southeast and kind of in that, I don't know, I guess Ohio is technically Midwest, but it's that far east part of the Midwest. And so there's that little area right there in the dark blue where there's still about a quarter of the population reporting cigarette use. And so this could tell you maybe, if you have poor birth outcomes in your area and you happen to be in, for example, Kentucky, maybe smoking is something that you might want to look into within your jurisdiction. And so some potential directions for addressing smoking if it is an issue where you are. There is increased availability of things like the quit line or the use of evidence-based smoking cessation programs that are promoted by healthcare providers. Nowadays, insurance companies are improving coverage for quitting methods for smoking cessation, and there are also increased public educational efforts and higher tobacco taxes. And so a quick, easy tobacco screen if you're interacting with patients or clients, you can ask them, 1, do you smoke cigarettes? And 2, do you have a smoke-free home? Is anybody else smoking in your home? And 3, do you have a smoke-free car? And so these are 3 very simple, straightforward questions that can give you an idea of whether or not the baby is being exposed to smoke. And there are other resources such as this. This is a screenshot of the community guide, their tobacco page. And websites such as these are really a resource you can go to for just kind of a list of different things that you can use to address tobacco in your community. So like in this screenshot, we see that they have information on, they cite the CDC and their best practices for comprehensive tobacco control. And there's, you can look at what the task force finds. You can see all of the information related to tobacco through this community guide. And here are some more evidence-based interventions. So the Community Preventative Services Task Force recommends comprehensive control programs and community communication interventions using evidence-based methods. A Cochrane review showed that psychosocial interventions, so things like counseling, group support, community education, can strongly influence smoking cessation among pregnant women. And the task force also recommends that clinicians provide counseling for all pregnant women about tobacco use, advising them to stop, and any applicable behavioral interventions for smoking cessation. So when it comes to monitoring your success in addressing smoking and smoking cessation, you can look at the birth certificate, but smoking is underreported. But you can also look at Burfus and Pram's survey data for smoking. And then you can also look at your local smoking policy changes, like have there been an increase in taxes or are there new bans in place? And then you can also look for funding or health insurance coverage for quitting. And so that could kind of give you information on the smoking status within your community. Any questions so far? Nothing in the chat box. If you've, at any point, if you want to interrupt us, that's fine. If you want to chat something into the chat box, feel free. So I'm going to go ahead and move on. So we're still talking about mortality. We went through a little bit about prematurity, a little bit about SIDS, SUIDs. And so next I'm going to go over stillbirth or fetal deaths. And so there are nearly as many stillbirths as there are infant deaths. And as with general infant mortality, we see large racial disparities within the U.S. And so you can see the 2013 rates for the non-Hispanic black population was 10.5, and for the non-Hispanic whites it was about half of that. So even with stillbirth or fetal deaths, we see similar patterns in terms of racial disparities. Carol says there was a question.
I'll read it. I don't know the answer to it, though. Do people usually understand what you mean when you ask if they have a smoke-free home or car? Has this question been validated with different populations? It's a good question, and I don't know the answer. Since this kind of question has been recommended by the people who do intense reviews of the literature, I think probably some validation has happened, but I can find out.
Thank you, Carol. Okay, so yeah, like I was saying, there are large racial disparities with stillbirth as there are with general infant mortality. And this chart just shows the racial trend, or I guess the time trend, and the continuation of the racial disparities. So since, the 1990 until 2006, the fetal mortality rate for the Black population has consistently been twice that of the white population, although they've been slightly declining, which I guess is good news. It's the silver lining in this case, but still a large racial disparity exists. And so for stillbirth, there are a number of risk factors that you can see here, things such as being overweight or obese or excessive weight gain while pregnant, maternal smoking, race, socioeconomic status, stressful life events, birth defects, short interpregnancy intervals. All of these things are known risk factors for stillbirth. And this is from the 90s. The article is from the early 2000s and uses data from the 90s, but we kept this slide in there because we don't think it has changed. The relationship between BMI and the risk for stillbirth is probably the same. And we can see here that there is an increasing adjusted hazard ratio with increasing BMI for stillbirth.
And then we have a question from Susan.
Okay.
What in the world happened between 1950 and 1990 to make the fetal death rate decline so quickly?
That is a good question. Carol, do you have any guesses for what happened in that?
It also looks like the Black rate was infinite at that time, too, so I'm not sure. I'm not sure enough about the history there, but
I'm thinking maybe the availability of birth control, and that's just a guess.
That did start in the 60s.
And it could be a function of better record keeping maybe, or I don't know. It could be a lot of different things, I think. That's a good question. Let's see if we can find out. We'll see if we find out, we'll update everybody. But yeah, so going back to what I was saying, there's an increase in risk for stillbirth with an increase in BMI. And even though this data is old, we presume that is unchanged. The relationship is unchanged. So there are some challenges in addressing stillbirth. The first being, what people really consider a stillbirth. And so sometimes stillbirths are recorded as live births, and early gestation stillbirths may not be counted at all. And so that could lead to some underreporting. And maternal and fetal characteristics are often missing from the death certificates, and cause of death is difficult to determine and not consistently recorded. And so we need more research and I think more quality control in terms of recording like maternal characteristics, fetal characteristics, and cause of death. And so that would give us a more complete fetal death file. Some modifiable risk factors to address stillbirth in your community includes birth spacing. Overweight and obesity is highly modifiable. And some recent improvements in assessment of cause of death. So increasing the number of autopsies or more information collected from autopsies could help identify the cause of death in the stillbirth. And so this slide also includes a couple of resources that you can look into for information on stillbirths. And the bottom one is pretty interesting because it's specifically about syphilis and its relationship to stillbirth, and so on. I think that always needs to be a part of the conversation. We always talk about maternal HIV, but maternal syphilis is also something that needs to be looked into, I think. And so if stillbirth is an issue in your community, you can monitor your success by looking at maternal obesity, maternal age, and birth spacing. And so if a lot of the moms are obese, then you can talk about nutrition, physical activity, things like that. And then if birth spacing, if the moms are having one baby every year, you can talk about family planning, introducing birth control just for that period of time for the 18 months that they should be waiting between pregnancies, things like that to improve maternal health, to reduce the risk for stillbirth. And as we've mentioned before, the data quality could be improved as well by increasing autopsies and doing quality control type things to decrease the number of missing elements from the fetal death record. And additionally, monitoring all live births, technically, plus fetal deaths for these risk factors is relevant to preventing stillbirths as well. Okay, so I've input another slide for questions. Anybody else have questions? Anything in the chat box? Okay, doesn't sound like it. So next is prematurity, and I think that is where Carol will step in. Let me see. Okay.
Carol, we cannot see your presentation.
I know. I didn't change it, so I don't know why it changed. Well, we can just see it from Liz. Why don't we just use it from yours?
Why don't you click next slide to see if I can see it?
All right, there. Now, does that look better? Can you see it now?
No.
No. That isn't how I did it before. Display settings, swap.
Go to share.
Is that better?
No. Well, go to the next slide.
Anything?
Nope. Let's have.
Can we have Lynne share it?
Yeah, let's do that.
Okay.
Lynne.
And I'll just share it off of yours. Okay. So we saw.
Do you see
no,
anything?
It looks black on mine. Yeah.
No. Go to the next slide.
Nope.
Okay, I can see your desktop.
Whose desktop?
Okay, let's see. Sorry, everyone. Now? Yeah. Okay. Yes. Yes. We're looking at my desktop, so just let me know if I'm clicking too fast or too slow.
Apologize for that. I don't know why it didn't work. But anyway, so what is prematurity? We're going to talk about that first, and go ahead to the next slide. So it's important because it contributes to infant mortality, which we've seen in several ways. It is a disparity. It contributes to disparities in infant mortality even more than it contributes to infant mortality. And it also is a birth outcome in its own right. prematurity really is not one thing. That's kind of my personal belief. So we often talk about overall preterm birth is less than 37 weeks, and that is important. But it's also important that very preterm birth, that is less than 32 weeks, and less than 37 weeks, moderately preterm birth, are very different things with very different causes. So we can look at different go ahead and change the different outcomes. There is a question, but I think it's just an answer to another question. Claudia Blackburn says, surfactant was introduced in 1990 affecting survival of premature babies. I don't think that would make a difference in the fetal death rate unless they were calling the babies fetal deaths when they were actually born alive and then died, which it did happen to some degree, but that might be one explanation. So full term versus early term is another difference in gestational age. Full term is now defined by the American College of Obstetrics and Gynecology as 39 to 40 weeks gestation. So even a baby that's not preterm can still be called early term if they're born at 37 to 38 weeks gestation. And it is a poor birth outcome, often caused by unnecessary elective induction or C-section. We haven't had very many Equity Institute issues about this because black women tend not to have this early term problem. Black women tend to have more of the very preterm problem. So go on to the next slide. Takes a while. So this is sort of a schematic of the causes and the root causes of prematurity. So risk factors for prematurity are definitely having a previous preterm birth, and that's a risk factor we can monitor in the vital records. Having an induction or C-section shouldn't be, but actually is a risk factor for late preterm birth. Preconception health is a problem, and that is can be caused by stress and chronic disease as well as other factors, and it doesn't just act during the pregnancy, but before the pregnancy over the woman's life course. Having a short cervix is actually more of a symptom than a cause. It's part of prematurity in most experts' estimation. Having a short interpregnancy interval is a risk factor for prematurity. Congenital anomalies do cause premature birth, and that can be caused, of course, by environmental exposures as well as maternal health. Twins, triplets, and smoking are other causes of prematurity. That's probably not a complete list. The contributions of causes of death to the black-white gap. This is a paper that was done by people at the National Center for Health Statistics to show that prematurity is indeed, just in terms of cause of death, it's something that we see all the time in our Kitagawa analysis, but in terms of cause of death, if you isolate the preterm-related causes, they are responsible for 54% of the black-white gap. So again, that's why prematurity often comes up as an issue in the Equity Institute. Go ahead. The percent of total infant deaths that are preterm related is higher for blacks. It is high for all of the groups, but it is higher for blacks. And this is 2013 data. Go ahead. So just a little illustration of what's going on with prematurity. It isn't common, but it is very dangerous. So the blue graph shows the frequency, the number of black births that are premature, the number of black births, and the preterm is 17.4% of all the births, and the very preterm is 3.8%. So it's those babies on the left. There are not very many of them, but if you look on the red chart, mortality by prematurity, mortality really increases rapidly. So if you're at 37 weeks, your infant mortality rate is 5 per 1,000. But if you go 32 weeks, 5 weeks earlier, the mortality rate quadruples to 20. And if you go 8 weeks earlier than that, at 24 weeks, the infant mortality rate is 360, and it goes even higher earlier. So mortality is high, and that's why it's such an issue, even though the numbers are small. Go ahead to the next one. And we did the similar slide for Native Americans, and the line is a little wiggly, I think, because the numbers are small on the deaths, but very preterm is less of a problem in the African American. It was 3-something, and now it's 2-something here for Native Americans. Very preterm isn't as much of a problem, but mortality is even higher for the Native Americans at these premature rates. A little bit different problems for the different groups. Go ahead. So there's 2 strategic directions for preventing deaths due to prematurity. So taking an aim at that prematurity disparity in mortality. So first, we could take better care of preterm babies. We could use those before birth steroids, antenatal steroids. We can control infections before, during, and after delivery. We can do really better care of preterm babies includes this kangaroo care, lots more skin-to-skin contact and breastfeeding. NICUs are always doing really innovative and wonderful things to try to get these babies to not only survive but to thrive better than they used to. But the second thing, and the thing we usually get involved with, is preventing that prematurity in the first place. So these are 2 very different areas, and that's why we have the Kitagawa method in our PPOR to try to distinguish which is the problem for us. And when we're talking about black infant mortality, it's usually that we have too many babies born too small, and that we need to prevent that very preterm birth in order to affect deaths. So this is the preterm birth rate by race again, black, white, and everybody. And you can see that they're narrowing. The difference is narrowing. The white rate's gone up a little bit, but the gap has been narrowing. Go ahead to the next slide. This is just a note that, and you may be able to use this in your to motivate your stakeholders and your funders, that premature babies cost a lot. I mean, there are some disadvantages in getting involved with cost, but prematurity is costly, and that does bring some people on board who might not be. And the more premature a baby is, of course, the more it costs. And this is only the cost of delivery. If you look at the cost over through childhood, it's even much higher, because the babies who are premature tend to have medical issues and also learning and social issues that cost. Different silos get involved with those. The education system starts to get involved, but costs are high. So go on. The risk of prematurity depends on the previous birth outcome. In the vital records data, we just have a tiny window into this. We have the question, was your last birth premature, I think is what we have, previous preterm birth. Maybe that, but this gets into a lot more detail about that. If you've had 2 previous births that are both term, your risk is very low. But if you've had a previous preterm earlier and then a term more recently, your risk is still pretty low. But if you've had a most recent birth being preterm, your risk gets high. And if you've had 2 previous preterm births, which is a surprising number of women, it's a very high risk. And that's why women who've had a history of preterm birth really need to be identified early, right after their current pregnancy. And that's sometimes a place where public health can get involved with making sure that that this information is passed on to the woman's health care provider, and the woman might be informed at that time of her risk and also followed up with. So some potential directions for interventions to reduce disparities in preterm birth rates. So going in that second direction. First, we can screen and treat medically those women who are high risk. Well, we can find out if they're at high risk by screening for their birth history and also measuring cervix length, two different ways, and then medical treatment. But somebody has to get those people to that medical treatment and set up that medical treatment. And progesterone programs are getting started all across the United States, but they're far from flowing smoothly, and sometimes they are not well utilized when they do exist. We can also increase the use of family planning. So to prevent a woman who keeps having preterm births from having too closely spaced births to try to get her healthy before she has another one. We can do educational programs to educate women and their support communities about the risk of the woman and also about how to support her so she's not quite as high risk, maybe even emotional support. We can also increase the pregnant woman's ability to cope with stress and depression and anxiety. There have been some research studies about this where some show that it actually does work. There's some positive results. I don't think it's to the point of quite evidence-based yet. Then we can also reduce her stress and her stressful life events for the woman when she's pregnant or even before she's pregnant or over her life course. So when we deal with children, we're dealing with future moms. Lakeithia asks, how do we measure the success of the interventions? And if you're talking about, that I'm going to get to that. That's one of the next slides. And if you want to ask specifically which interventions, you can type in another question. So intervention points for prematurity prevention. So medical care if labor begins early, prenatal care, preconception care, and life course care, and then policies to create social change.
Carol,
can
I interrupt you for a question?
You bet.
How do you measure the success of the interventions?
No, I already read that question.
Oh, you did? Okay.
I'm just going to get to it in a second. Mm-hmm. Since I'm not doing the slides, I can see the questions. Oh, there, she said, the success of educating the women. There's a few reviews about this that I think I have a slide about. So hang on just a second. Thanks, Lakeithia. I'll get that question. Go ahead to the next one. Let's see. Okay, some interventions for prematurity. So there is a Cochrane review that concluded that we don't know whether periodontal treatment works. So dental stuff has been in controversy, comes in and out of favor. But the current review that's very extensive says, no, we don't know yet. We don't have enough evidence. Just in case you were thinking about dental stuff, it's not quite clear. So social support reduced the preterm rate among women with high stress levels in 2 randomized controlled trials. So pretty good evidence that social support worked only among women with high stress levels, and that came out in 2015. Psychosocial interventions reduced the risk of low birth weight in teenagers by 40%. And then cervical cerclage reduced preterm birth among women with short cervix. And measuring cervical length is not an easy process. That's something that has to be done carefully and trained for. And then there's the Cochrane review that concluded that progesterone treatment reduces preterm birth among women with a prior preterm birth or short cervix, and that's not 17P. The 17P evidence is a little weak. Now, back to that question about educating women, that is not on this slide, but there are some studies about educating women about how to deal with stress, educating them about to go to the doctor when they have symptoms of stress. I think there is some strong evidence of that because there are treatments. Tocolysis is the treatments that they can get to. If they are actually in labor, then they can reduce their risk of delivering right away by going to the doctor right away, but they have to know to go into the doctor, and those kind of education things work. There's some other stuff about educating that I don't think there's not been strong studies on. It's really hard to keep up with all this, so I can't claim that I am up on everything. And the studies of 17P, I think I have read a lot about 17P, and although it is what the March of Dimes has been promoting for a long time, I think it's based on some studies that have been criticized. So I think the evidence is not as strong as what we wish it would be. There are some downsides of 17p1. It's an injection, and the woman has to get the injection every week for a certain number of weeks during her pregnancy. And if she stops for some reason, she actually can increase her risk of prematurity. So the 17p, it's not. It certainly is. It's more accepted right now than progesterone. Until there are some studies, recent studies coming out that just vaginal progesterone is working. But the medical community, the medical research community, is still kind of duking it out over those. Which one's better, which one really works. But it's pretty obvious that they work. That generally progesterone 17p does have an effect. But it's not. It hasn't all been ironed out. What should be done? So here's an example of trying to get at those upstream things. This is a real thing that's happening still in Boston, and some other cities are adopting this method too, of taking the women who are at the most risk, say women who are under high stress because they don't even have housing, and just providing housing. In Boston, Debbie Allen told us this story, was that they went to the housing authority and convinced them to allocate some really low subsidy, low cost housing to those pregnant women in exchange for providing the caseworker support of those women. It was a win for the housing authority because they got help with making sure that those renters knew how to take care of their home and knew how to make the utilities payments or whatever was in, because these are often people who have not had their own home and don't know how to do this. So it helped the housing authority to have some support around the women who were living in those homes, and it helped the women. And Boston is still monitoring the health effects of this. It takes a while to get enough numbers through to measure a difference. So here we go. How do we measure the difference? Monitoring our success. If we're doing a program, we can to give more access to treatments like 17p and progesterone. It's important that our program data be shared with us so we can know exactly how many women are presenting at these clinics that do this, and then how many are newly receiving 17p and progesterone. So if you set one of these up as part of your equity institutes, you have to really be partnering with the clinics that are doing this. We can also monitor policy data, like having health insurance postpartum that'll pay for your family planning when you're ready to get it, not just within the first 5 or 6 weeks when you're covered. That doesn't work for everyone. And there are also policies that hospitals can institute and have in many places where they will insert LARCs right away when the woman is in there to deliver. And that makes it much easier for her if that's what she wants. She can do long-term prevention of pregnancy right there. And I think public health has been involved in not making these things seem forced too. That we don't want to have women feel that they're railroaded, and I think public health can be helpful there too. And then we also have to monitor population data, and we can because we have prematurity in the birth certificate. And birth certificates actually can come out fairly quickly. Some states are producing quarterly provisional estimates, and so you can monitor prematurity more easily. It's much more difficult to monitor infant mortality because then you have to wait until a whole year after the babies are born, so you might have late monitoring. But for prematurity, you can monitor it in the birth certificate and get almost timely data. I wouldn't really say timely, but a little bit better. And then those social determinants are in the census, and you can get that. Both of those sources you can get at the very, very local level, census and vital records, and we should be using that to monitor our success. Any questions about prematurity? There already were some. Don't see any questions yet. I'm waiting. Well, Lynne can go ahead and talk about the next section.
Okay, so if you do have a question that comes up, feel free to type it in the chat box or unmute yourself using *7 and just go ahead and speak up. So I'm going to continue with unwanted pregnancies, teen pregnancies, and short birth spacing. So this really is just a schematic of what goes into unwanted pregnancies, teen pregnancies, and really that's just due to a lack of family planning. And so in the middle there you see costs and availability and lack of utilization, and we think those are two things that lead to unwanted pregnancies or teen pregnancies. And so the cost and availability of effective birth control methods can be determined by a lack of insurance coverage, or maybe the clinic is too far and I can't get to the clinic to get birth control. Or, if the clinic is nearby and my insurance does cover it, maybe I don't want to go to that clinic to talk about it because they're not very nice. So clinic friendliness and cultural sensitivity could be implicated in the lack of utilization of birth control. And community and patient knowledge of birth control methods is also an important part of family planning, of course. And family planning really is more than just birth control methods. It's a social issue because providers and patients need to see the relevance of planning, to how relevant it is to their health and well-being, and how it fits into their life. Are they stable? Are they financially stable? Are they at a good time to have a baby? And then for the younger moms, like teenage mothers or early 20s, they need to develop a sense of future opportunity, and so they need to have the option of delaying parenthood. Like maybe they do want to have kids eventually, but they're teenagers, so they're not quite ready for that. And so it's a social issue, just this access to family planning information and family planning methods like birth control is important. And so this slide specifically talks about short birth spacing because it is modifiable, and it is implicated in a lot of poor birth outcomes such as stillbirth, low birth weight, early neonatal deaths, and there is a relationship between short birth spacing and maternal overweight and obesity. And even without all of these health benefits, community rates of poor outcomes would automatically decrease if high-risk women had pregnancies every 3 years instead of every year. And so basically what that's saying is that short birth spacing can have a significant impact on poor birth outcomes. And so if women have access to family planning information and methods like birth control, the risk for poor birth outcomes can be reduced. Pregnancies can happen if/when they are wanted and when the parents are ready. And so one example we have of family planning is the Choice Project out of St. Louis. And so they've worked really hard to provide LARCs to women in their community, both by increasing education and availability and provision through clinics. And so efforts such as this can help reduce barriers faced by women who are looking for birth control as a family planning method. We just, as Carol mentioned, we just have to be careful about coercion. So we can't kind of force them into a corner about LARCs. They need to know that the choice is out there and they can make that choice, but we just don't want to force them into that choice or make them feel like they're forced into that choice. So that was just a quick bit on family planning. I haven't heard anything about questions, but again, feel free. So I'm going to go ahead and move on to a failure to initiate or sustain breastfeeding as another birth outcome that is often examined in the Equity Institute. And so for the Equity Institute, and probably for any project that we have, any measurable change that decreases a disparity in breastfeeding initiation or continuation will count, I guess, as a measurable outcome for your project.
There is a question about family planning.
We have a couple of questions, but
okay.
Let me just, I know that Sarah Landry from KU is on the line. I'm not putting any pressure on you, but if there's something when we're talking about measurement that you think you can provide some feedback to, by all means feel free to press *7 and give us your feedback. So we have a question, not a question, but a comment from Lakeithia. Prematurity follow-up question. Instead of monitoring the intervention, should you just reevaluate the prematurity data since the intervention is aimed towards reducing prematurity? And that is the question.
Well, I think you should do both. You can measure, you can monitor the programs in the measurement slide. Usually we talk about both program data, monitoring the intervention, but also monitoring the outcome. Yes, you can do that, both. I mean, usually program data comes quicker. And does that answer your question? You can't answer fast enough.
Yeah, and the other question is, what is the appropriate minimum age to address family planning preconception care, i.e. high school, college?
Well, it's kind of a tough question, but I would feel like it would be most relevant for high schoolers, just because I think, if they're not already being faced with having safe sex or not, like they're quickly approaching that point in their lives, and so I think it would be most effective in high school, maybe
you
earlier.
asked for the minimum age, so you're
implying
earlier. That there's some age where it's so young that it's inappropriate, like age inappropriate, and I don't know if there's research on that or not.
And I think a lot of that depends on how your community feels about sex ed, because there's some that are more open to comprehensive and some that are a little more hesitant about it. And so I think a lot of that depends on the community specifically. But I do think, the conversation should be happening in colleges as well, but high school I think would be earlier or a little better than starting the conversation in college.
There's some communities where this is a sensitive topic where they instead train the parents to talk about it or do it through the parents in some other way. I remember New Mexico having something like Tupperware parties about family planning where the moms would be there and their teenage daughters would also be there, and they would talk about it together, and they felt more control over it in that case. So very young age is maybe it's better to get parents involved.
Are there any other questions in the box, Carol?
Yes, I wanted to invite Lakeithia. Can you unmute yourself?
*7.
*7, so we can clarify your question and make sure that we address it.
Hi, it's Lakeithia. Can you hear me?
Yes,
yep.
Okay, so my question was around, and it's only because, we're getting close to narrowing in on a strategy, and when you have strategies around education and reducing stress and things of that nature, that really can seem ambiguous. And how do you really measure that I've reduced your stress? And so when you said program data, that's why I put a question mark to kind of expand on what that looks like in terms of measuring success in interventions specifically.
Well, I know a particular study that I was really impressed by was funded by the NIH in Washington, D.C., and it was a large study, and they took women who are at high risk and high stress levels, and they did some training, kind of mindfulness type training, like how do you calm yourself down, really simple things, and they were actually able to follow up and show that it reduced the very preterm birth rate. I think that's the only thing it reduced was the very preterm birth rate. But it would depend a lot on the program. I don't think we could give you an answer for your, a general answer of how you track program data. But in that case, they were able to follow up with the women. They had incentives to keep the women involved, and they had to go to 3 sessions or something like that. I don't remember the details, but that kind of, if you had a program where you couldn't follow up with a woman, you'd be in the position of you have to take some kind of measurement right there when you gave it. Maybe you could take their blood pressure before and after. Maybe there's another biological thing. Or you could just ask them, did we reduce your stress? And I don't think that would be as as effective, of course, as following up. But if you can't do it longitudinally with the woman, then maybe some kind of physical measure of stress would be a better solution than just asking them. Does that help? Go ahead and talk about your program.
That is helpful. So we actually had our community meeting last night, and one of the strategies we're looking at is coaching Black men and women on how to be their own health advocates during the prenatal care visits and appointments. And when we spoke about that strategy in particular with the larger community, stress obviously came up. Navigating healthcare systems came up. Experiences in healthcare came up. I guess you answered my question, because really what I was getting at is what methods are you using? Is it surveys? Is it, I think that's a great idea about the blood pressure, but just more granular level methodologies to capture the success of what could be an ambiguous strategy in terms of, measurements, because we can look year over year at preterm labor statistics, but when we're looking at if education is successful, what methodologies are we using to measure that? So you did answer my question. Thank you.
And I think that it could be better answered with a little bit of looking at some scientific literature. Do you have access to PubMed or anything like that?
Yeah.
Yeah. Because good studies do come up now and then there's no reason we shouldn't copy them.
Okay.
Oh, here, somebody else.
Yes, we have a comment based on the last question. It says, I think we must promote comprehensive health ed with the focus on middle school appropriately tracked. And we have another question. It says, would it be appropriate to use tools such as PHQ-9 and KH/KH8 to track mental health data?
Can you tell us what those are? Do you think they're appropriate?
Star 7.
Can you hear me? This is Sarah.
Hi, Sarah.
Go ahead.
Hi. Sorry, I was having trouble figuring out how to speak. I am familiar with the PHQ-9, and that is a validated tool. So in terms of being able to do quick measurements around depression or anxiety, I think I've seen that often used in different studies. So I think that would be good. And I think in terms of the stress as well, I think with some digging and understanding more detail about what the program involves overall, that there's likely validated measures out there to kind of get at stress. So it's not just coming up with your own survey questions and asking kind of vague questions, but kind of getting more to good clinical questions that help measure the concept of stress a little bit more accurately if self-reporting is the way you have to go.
Both of those are not you wouldn't do those before and after on the same day, because they're both questions about how you feel in general. So you wouldn't expect them to change after a session, an educational session or something. Somebody provided a link. Go ahead, Sarah.
Yeah, no, that's okay. Yeah, I think knowledge in itself and the education piece is something separate, and then tools like the PHQ-9 or some other kind of measure of stress would be things that you would administer over time with the same set of people or population you're surveying to see change.
Somebody, Peggy Vandermeulen, said PSS4 is a validated tool for stress. This is helpful. We should post these.
Yeah, definitely. Okay. If there are no other questions or follow-up comments, I'm going to go ahead and move on. We will be sure to post, the recording of this so that you can catch all of this audio. But 2, we'll post information about PHQ-9 and the PSS4. That's very helpful. Thank you. So going back to breastfeeding, as I mentioned for the Equity Institute and probably Collective Impact or other projects going on, any measurable change in breastfeeding behavior is an acceptable outcome measure for your project. And I know I'm basically preaching to the choir here, but there are 1,000,001 benefits to breastfeeding for both mom and baby, and so it's cheaper, and it provides the baby with certain antibodies and nutrients that wouldn't otherwise be available through formula. And it reduces the risk of asthma, allergies. It improves your immune system, the baby's immune system. It reduces ear infections, hospitalizations, reduces risk of SIDS, SUIDs, and reduces the mother's risk of breast and ovarian cancer. And so these are just things that you can use to promote the importance of breastfeeding. Some potential directions for increasing breastfeeding in Black women specifically. We've seen group prenatal care target breastfeeding, peer counseling and WIC clinics, education campaigns, and baby-friendly hospitals are definitely a big help in increasing breastfeeding. And I think that was it on breastfeeding. We didn't have too much information, but it's pretty straightforward. And there's a lot of information that you can find on PubMed or just any other public health website about breastfeeding. So I'm going to go ahead and move on to infant morbidities. So this is a list of just like some examples of morbidities such as prematurity, birth defects, exposure to syphilis, HIV, and now Zika, we're finding, exposure to alcohol, opioids, other substances, and then injuries from accidents and assault. So to measure infant morbidities such as these, we can look at hospitalization and emergency room data, specifically for injuries after delivery. The CDC is a resource for detecting and preventing birth defects and developmental disabilities, including prevention of substance-exposed pregnancies. And the National Center for Child Death Review and a gentleman named Steve Wirtz of the California Department of Public Health are valuable resources for child abuse and neglect, surveillance, and prevention. And so that was it on infant morbidities, and now we're going to talk a little bit about maternal mortality and morbidities, which may be difficult to measure because of small numbers of maternal deaths. But something we have talked about and is certainly a really big deal in pregnancies is maternal overweight and obesity, because this being overweight or obese is linked to so many different things that can affect the outcome of your birth. So like having gestational diabetes can affect preeclampsia or the risk for preterm birth and future diabetes in your child. And being overweight or obese can increase your risk of stillbirth, congenital anomalies, neonatal mortality, and just a whole slew of other things. And being overweight and obesity is important because it is highly modifiable. So some information on overweight and obesity in certain populations. So we found that approximately 2/3 of non-Hispanic Black women of reproductive age are overweight or obese, and non-Hispanic Black mothers are more likely to be obese, and non-Hispanic Black women are more likely to experience excess weight gain during pregnancy. And obesity, chronic hypertension, diabetes are more common among non-Hispanic Black mothers. And similarly for American Indian or Alaska Native populations, same about 2/3 or 65% of American Indian, Alaska Native women over the age of 18 are overweight or obese. They are at greater risk for developing gestational diabetes, and approximately 45% of American Indian or Alaska Native mothers are overweight or obese. And obesity is definitely related to stillbirth, and so obese mothers are 50% more likely to experience stillbirth than normal weight mothers. And the risk is greater still for obese non-Hispanic Black mothers compared to non-Hispanic white mothers. And risk for stillbirth increases with increasing BMI for both Black and white populations alike. And the risk of neonatal, early, and late neonatal mortality is increased significantly with increasing BMI among non-Hispanic Black women, found by Salu in, I don't remember, it was in a 2008 publication. But yes, that is what they found. And then, as we can surmise, preeclampsia diabetes is related to poor birth outcomes, and obesity is related to preeclampsia and diabetes. And so non-Hispanic Black women with preeclampsia are more likely to have low birth weight babies, and non-Hispanic Black women with diabetes are more likely to have a preterm birth. And so all of these things go to say that, like, if you could address overweight and obesity within your jurisdiction, if it is a large issue for you, it could have so many ripple effects in birth outcomes and health of the mother and the child. And so this is definitely a big, I guess it would be called low-hanging fruit in terms of addressing things like low birth weight, preterm birth. And so eliminating obesity during pregnancy could prevent almost 7,000 fetal deaths per year, and that is according to a study in 2013. And maternal overweight/obesity was the highest-ranking modifiable risk factor in a study of stillbirth risk factors in high-income countries. Some potential directions for reducing maternal obesity includes increasing physical activity prior to and during pregnancy, better quality of diet, tax and economic incentives, legislation to strengthen insurance coverage for obesity prevention and treatment like gym memberships, psychosocial interventions, again, similar to like counseling, either through your clinic or through any other group care type situation, behavioral counseling, and breastfeeding to prevent postpartum weight gain. And so I think that was the last slide for the obesity section. Yes, so this is basically the end of our presentation, and we hope that, I know that we covered a lot of different things, but we hope that you were able to take away either some data sources that you might be able to look into, or maybe you were able to identify some risk factors that you can examine in your work or in certain areas of your work, and maybe some new facts or stats that you didn't previously know. We hope that you were able to take at least something away from our presentation. And let's see, what time is it? We've got 12 minutes. So if you've got any questions, any comments, feel free.
There's a question from Fiona Weeks about interventions for preventing obesity, and I'm thinking that Sarah might be better at answering that than us. How is obesity, overweightness low-hanging fruit? Do you know any specific interventions that are highly effective at helping women achieve and maintain significant weight loss? And that's two questions, really, because women who are pregnant already is a different issue from women who are not pregnant yet. And then somebody else, Ida Hen, also said, also addressing preconception health at the primary care level to heighten awareness of co-occurring issues and birth outcome. How are we expanding the conversation? Educational efforts to include PCs, primary cares, or preconception, PC, primary cares, I think she means. Are other Equity Institute folks focusing on housing? Have you seen evidence-based interventions that you can share? Another question, that's great. Are these PowerPoints available for me to share with our perinatal health educators? Yes, the PowerPoints are going to be posted. The PowerPoint is going to be posted. So I know that Tennessee right now is starting to work on housing, and there are other places that I've heard of. Tennessee is one I'm thinking of. But the housing has been worked on. I don't know about, there's nothing evidence-based on housing yet. There's no publications that say, yes, we've reviewed all these randomized controlled trials and housing works. I think Boston is the closest to pulling out some evidence on that. Sarah, are you still there? I know you guys have done quite a bit of work on obesity, so I think maybe you...
Yep, I'm here. And so the question was just in general, what were some interventions for obesity? Was that the question? Evidence-based. I would hate to speak off the cuff there. I mean, when you think about the scale and reach of interventions, oftentimes when it comes to obesity, environmental and policy changes can be found to be really effective, obviously, in reaching a broad group of the population. So thinking about things like and when we're thinking about women who are already pregnant, that's obviously, like you said, Carol, different. But environmental changes around, access to physical activity and changing the nutrition environment, are things that have found to be pretty effective at reducing obesity at a population level. I would be happy to look into that a little bit more and see what other kind of evidence-based, maybe a little more programmatic or policy-focused might be there, especially in terms of maternal health, and get back to you on that.
The community guide did have some listed. If you go to the community guide, that's a quick way to find things that have really strong evidence. And you can find, it's easy to find one or two studies just by searching in the literature. And there are studies that show that you can impact maternal obesity by doing this or that. But getting reproducible studies is a kind of a different story, and that's where you go to something like the Cochrane or the community guide to help you really take a good look at those studies. So we can help with that. I mean, I have done it, but it's really hard to keep up with up to date on all the literature on all these topics at the same time. So we'll have to look those up. Peggy Vandermeulen has written, there is a wealth of research showing that it is the chronic stress of a lifetime exposure to racism and discrimination, both individual and institutional, that is the underlying cause of the disparities in birth outcomes between whites and blacks. Is it that it is not being black that puts you at risk? Rather, how are you treated for being black? What type of evidence-based models are out there for addressing racism? Or maybe that's a topic for another webinar. Yeah, we could do a whole webinar just on that. But that's a good point to bring up. And changing racism, there are a lot of people working on that right now, and I don't know what the state of the evidence is, whether we have gotten proven ways to change it. There are two follow-up questions from Christine about, obesity prevention and reproductive age, who live in neighborhoods that are unsafe or do not provide healthy places to exercise and play. That's a good question, and that I think Sarah got at that a little bit. That obesity is not just about personal behavior; it's about overall systems and policies and how neighborhoods are. And Christine follows up with studies addressing obesity prevention for neighborhoods that are food deserts, and also present transportation barriers to the closest medical service. And I know that there's a lot of people studying this too, and it's difficult to study food deserts. Some people at our university are trying to study that, and and the Department of Agriculture actually maps out where food deserts are. That is where grocery stores are not, healthy, real grocery stores. But it's tricky to factor in transportation access, because there are many neighborhoods where everyone has a car and they don't have a grocery store, but it's no big deal. But if everyone doesn't have a car and there are no grocery stores, it's a whole different ball of wax, and they have much less access to healthy food. So these are good questions getting at really tough issues, and the evidence is not as strong as it needs to be. The evidence in chronic disease is what we need to borrow from, because chronic disease section of public health is really putting some money into this stuff. And I know that KU was very involved in the Healthy Communities study that did some some work in exactly this kind of stuff, only for children, but what policies actually help with changing people's obesity and physical nutrition and physical activity. And the results of that are just coming out. So,
any more questions before we go?
These are good questions. Thank you for all the questions. Did we miss anybody? I'm trying to look through. Monica, have we asked them all that you see? I think we got them.
I think so, but raise your hand if not. Okay.
I think we did.
So I will send out the recording and the slides and also the contact information for Carol and Lynne if you have any follow-up questions. Anything else you ladies have, Carol, Lynne?
Nope, we're good. Thank you.
Well, thank you so much for coming and sticking around. Have a good Labor Day weekend.
All right. Bye-bye.
Thanks, everyone.